Hello, everyone, and welcome to today's webinar titled Best Practices to Recover from an Out-of-Control Event. I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. This educational web seminar is sponsored by Biorad Laboratories. Now, I invite everyone to participate by submitting your questions during the presentation. To do so, simply type them into the Ask a Question box located on the far left of your screen and click the Send button. Any questions we don't answer during the webinar will be captured and responded through the Q&A list that will be posted next week in the Event Resources box, which will be located on the right-hand side. You will also be able to download the presentation handouts from this Event Resource box starting July 1st. Now, if you have any technical trouble seeing or hearing this presentation, simply contact us in that Ask a Question box, and we will address your issue. As a reminder, this presentation is educational and offers free PACE continuing education credits. Click on the Continuing Education Credits tab located at the top right corner of the presentation window and follow the instructions to obtain your credits. Now let's get started. I now present today's speaker, Dr. Lorin Bachmann. Dr. Bachmann is an associate professor of pathology and co-director of clinical chemistry at the Virginia Commonwealth University Medical Center. She is currently serving on numerous committees, including the American Association for Clinical Chemistry, Finance and Nominating Committees, and the College of American Pathology Accuracy-Based Programs Committee. Dr. Bachmann serves as chair of the Clinical and Laboratory Standards Institute Expert Panel on Clinical Chemistry and Toxicology, and Dr. Bachmann's research and clinical interests include development of laboratory practice guidelines, standardization of clinical laboratory assays, and quality assurance. For a complete biography of Dr. Bachmann, please visit the Biography tab at the top of your screen. Dr. Bachmann, welcome. You may now begin your presentation.
Okay, so thank you very much for the introduction, and thank you to Biorad for supporting today's webinar. So today we're going to discuss a systematic approach to recovery from an out-of-control event in the clinical lab. An out-of-control event occurs when a QC rule evaluation for one or more QC measurements yields unacceptable results. So these are my disclosures. So after today's presentations, participants should be able to identify the first steps to take after an out-of-control event occurs in the lab, discuss how to evaluate patient results after the out-of-control event, for example, what is the magnitude of the impact of the event on patient results, and do corrected reports need to be issued, and outline approaches not only to correct patient results, but also to implement actions that prevent recurrence of the out-of-control condition. The primary reference that will be used as the basis of the recommendations is the Clinical and Laboratory Standards Institute document C24, Statistical Quality Control for Quantitative Measurement Procedures. This CLSI guideline issues recommendations for designing an effective QC strategy, including defining quality requirements, selection of QC materials and frequency of QC analysis, establishment of QC target means and SDs, troubleshooting recommendations, and recovery from out-of-control conditions. The document can be found on the CLSI website listed at the top of the slide. So laboratory errors have been shown to cause harm to patients and also increase the cost of healthcare. In this study, investigators examined more than 40,000 laboratory measurements conducted in a high-volume stat laboratory over a time period of 3 months. They found a laboratory error rate of almost 0.5%. If you think about that in the context of how many tests your lab performs a day, that's actually a significant error rate. The study showed that 6.4% of the laboratory errors led to incorrect patient care decisions or inappropriate treatments. 19% of the errors resulted in unnecessary diagnostic workups that increased the cost to patient and to the healthcare system. This slide shows the different categories of laboratory errors and their sources. A study published in Laboratory Medicine in 2012 found that errors in the pre-analytical phase, like specimen mislabeling or specimens collected into the wrong container type, comprise the majority of laboratory errors. Errors in the post-analytical phase included incorrect result interpretation or failure to call back critical values in a timely manner, also formed a large percent of the errors. However, analytical measuring system errors, or errors originating from the analytical phase of testing, represented a significant portion of the overall error rate. Another study that examined more than 670,000 proficiency testing survey submissions from more than 600 laboratories found that PT failures due to errors in the analytical phase of testing consisted most frequently of instrument errors, like the instrument needed maintenance or an instrument malfunction, followed by calibration errors. For example, the assay was miscalibrated or calibrators were prepared improperly, and then reagent errors, such as reduced stability of onboard reagents. The laboratory's routine quality control program is designed to evaluate the analytical performance of the measuring system and to detect potential errors in the analytical phase of testing. So for a standard laboratory statistical quality control program, QC materials are integrated into the patient testing workflow and analyzed along with patient specimens at a frequency established by the lab. For example, the lab may run QC every shift or every 12 hours. The acceptance criteria are typically based on rules that assess the standard deviation intervals for the QC results. The SDIs are calculated from the observed values along with the QC target means and target SDs. The QC target means and SDs are established during initial method validation and refined as a result of ongoing performance monitoring. In this slide, patient samples are represented by the blue striped rectangles, and the QC material is indicated by the black rectangle. The graph below shows QC results obtained over time, with the green bars representing the limits of the acceptable range. If the measuring system is performing as expected, QC will be within the acceptable range, and we are confident in the quality of the patient results. QC values that exceed acceptance limits, representing an out-of-control event, may indicate an out-of-control condition, which is where the measurement procedure is not performing as expected. Out-of-control conditions are usually identified by a shift or drift in QC values away from the target mean or an increase in imprecision. QC drifts, shifts, or increase in precision identified by an out-of-control alert means that something happened to the measuring system that may cause erroneous patient results. This slide shows some common causes of out-of-control events, or QC failures. One of the most frequent causes of QC failure is a problem with the QC material itself. So the QC material might be improperly reconstituted or improperly stored, like for example, left out on the bench too long. The wrong QC material could be analyzed, or the lab could be using an inappropriate QC target mean, or SD, established on an inadequate amount of data for a new lot, for example. QC failure can represent a problem with the reagent, so improper reagent formulation or preparation, onboard degradation of the reagent, which is actually a very common cause for QC failure, altered shelf life for a new lot, for example, reagents that are improperly stored, or reagents that have inappropriate QC target means for a new reagent lot. So we have to remember that QC is actually a contrived material. It has additives and preservatives. It's manipulated differently than patient samples when it's being prepared by the manufacturer. And so it can have what's called a matrix effect, which means that since the QC matrix is different from that of native patient samples, the QC material can interact differently with the new reagent lot than the patient samples do. So when you implement a new reagent lot, QC can shift while there is no difference in the patient sample results. If this happens, then the QC mean needs to be adjusted to reflect the performance for the new lot. So QC can easily fail if there is a matrix effect with a new lot of QC material and the mean has not been adjusted. So QC can fail with a problem with the calibrator, so improper calibrator formulation or target value assignment by the manufacturer. Calibrators can be improperly prepared or reconstituted by the lab, or the lab could be using the improper calibration frequency. QC can fail due to an instrument problem, so lamp degradation, like for a spectrophotometry assay, a leak in instrument tubing, or damaged pipetter seals, mixer failures, pump failures, all those are common causes of QC failures. QC can fail due to inadequate maintenance, so inadequate cleaning or decontamination, wearing of parts for the instrument. and also improper procedures. So QC can fail because the techs fail to follow the standard operating procedures of the lab, or the SOPs are inadequate, or the training program is inadequate. So there are a lot of causes for QC failure, so it can be really difficult to know where to start once a QC alert is received. So this table shows level 1 QC results for a total calcium assay. The QC failed acceptance criteria and was flagged low on February 16th, which is shown in red. You can see that the assay looks like it's been trending in a downward direction over the previous couple of days, from a positive 1.4 SDI on February 13th down to a negative 3.6 SDI from the mean on February 16th. And an alert was triggered during the morning QC run. So what are the first steps that should be taken with this type of out-of-control event? This slide shows a basic pathway for responding to an out-of-control event. The first step that has to happen is actual detection of the analytical measuring system error. An automated QC rule needs to fire to alert the technologist of a potential problem, or the technologist needs to recognize that the result has failed acceptance criteria if using manual QC review. Once a QC alert is received, the first thing the technologist should do is immediately stop reporting patient results. The QC alert means that there is potentially an error in the analytical measurement system that could cause harm to patients. Therefore, reporting must be stopped and the issue needs to be investigated. The next step is to perform an investigation to determine the root cause of the problem. The root cause is the actual reason for the presence of the analytical measuring system error. Oftentimes, a problem is initially identified, but it's actually not the root cause. For example, QC may fail due to a calibration drift, but that's not the real problem. It's only signaling an underlying problem. Perhaps the routine calibration frequency is inadequate for the stability of the reagent, or maintenance is not performed frequently enough and the instrument is becoming contaminated. So it's really important to determine the actual root cause of the problem so that it can be directly addressed through corrective and preventative actions. Then the fourth step is to implement a corrective action to correct the problem so that the testing can get back up and running as quickly as possible. It's not uncommon that we feel like the response to a QC failure sort of ends with corrective action. Great, we've fixed the problem, and now we can resume patient sample testing. However, there are still a number of steps remaining to adequately recover from an out-of-control event. The next step is to evaluate the impact on previously reported patient results. If we're running QC every 12 hours, for example, and we have an out-of-control event, the actual analytical measurement problem could have happened 6 hours ago, and we've been reporting erroneous results without realizing it that whole time. This means that previously analyzed patient samples need to be reanalyzed after corrective action and evaluated to see if the magnitude of the original error was such that the error could have caused a clinical impact, like wrong patient treatments based on the erroneous results. Then we need to mitigate or reduce any potential patient harm that resulted from the erroneous results. This is accomplished by issuing corrective reports and calling those corrections to the ordering providers so that they are aware and they can take any necessary steps to change their clinical course of action. Broad communications may also need to be issued to all of the laboratory's clients. The last step of the recovery process is to implement a preventative action plan. Preventative action is not only correcting the problem in the short term, but ensuring that the problem does not reoccur. That could mean replacing parts or scheduling instrument maintenance more frequently, or changing QC rules so they detect the problem earlier. Of course, be sure to document the entire process to the out-of-control event from the point of error detection to the final preventative action plan. To quickly detect an analytical measuring system error, an effective QC program needs to be established. The QC target means and SDs should be established using an adequate amount of data. The CLSI C24 document recommends analyzing new lots of QC for at least 20 days to establish a target mean for a new lot of QC material. The SD is not a function of the new lot of QC material, but rather a function of the analytical measurement system performance. Therefore, target SDs should be calculated using historical data, usually including several months' worth of QC data, to incorporate multiple sources of variation, such as different calibration events and different reagent lots. QC multi-rules should be established to detect increased random error or imprecision, and also increased systematic error or shifts and trends. So the multi-rules that we commonly use include a 1-3S rule, which is one QC result that exceeds 3 standard deviations from the mean. The 2.5 within and across rule, which is 2 consecutive QC results exceed 2.5 SDs from the mean, either within a control or between 2 controls like level 1 and level 2. An 1.5S rule, which is where 8 consecutive QC results exceed 1.5 SDIs from the mean. And a range 4S rule, which is where 2 consecutive QC results within a control exceed a range of 4 standard deviations. So techs should also be examining Levy-Jennings charts whenever alerts fire to determine if an out-of-control condition is occurring. Once an alert is detected, the technologist should ensure that all patient result reporting is stopped for that assay. This could include taking the assay out of service or even taking the entire analyzer offline if necessary. Be sure to turn off auto-verification if auto-verification is performed in your lab so that results are not automatically reported into the medical record. The second step is to quickly determine the scope of the problem. Check the other levels of QC for that assay to see if they are affected. Check QC for other analytes on the same analyzer to see if they are also affected, which would suggest an analyzer problem and that the entire analyzer needs to be taken offline. Also, check QC on other instruments to see if the problem is affecting multiple analyzers. That would clue you in that the event is due to something in common with multiple analyzers, such as reagents, and would suggest that you need to take the assay offline on more than one analyzer. You definitely want to look for other QC values that are about to fail the QC rules, so you can get more insights into the nature of the problem and can figure out which assays or instruments you need to immediately take offline. Once the assay or analyzer is taken out of service, troubleshooting can begin. The Levy-Jennings charts can be examined to see if there are any shifts or trends developing, and if we can pinpoint the date and time the problem started. We can check the laboratory records to see if any new reagent lots or calibrator lots were first implemented when the problem started. We can check the status of the maintenance records for the instruments. Were there any recent issues or parts replaced? So these types of investigations can provide clues about the root cause of the problem. The good news is that we do have tools to evaluate recent assay performance. So we can, again, look at Levy-Jennings charts and QC multi-rules. We can look at the performance of the assay and the different analyzers using the daily, weekly, and monthly QC results. We can look at routine laboratory records like calibration records, reagent and calibrator lot change records, maintenance logs, and temperature charts. We can look at other laboratory quality assurance records like 6-month linearity checks and among instrument comparisons to get clues about what is going on. There are some more sophisticated tools that we can access to evaluate recent assay performance, like peer group QC data and patient-based real-time QC monitoring that we will discuss later in the presentation. So now we have detected the error and stopped reporting patient results. We have examined the Levy-Jennings charts for the QC, as shown in the bottom of the slide. We have reviewed our records, and nothing really seemed amiss except for a slight downward trend in QC results over the past couple of days that could be seen on the Levy-Jennings chart. One of the first troubleshooting steps you can perform to determine the root cause of a problem is to repeat the QC analysis using a fresh container of QC material. Do not just repeat the QC from the same aliquot or vial of QC material, because this does not constitute an intervention. You actually want to go into the refrigerator, obtain a new unopened vial of QC material, and repeat the measurement on the fresh aliquot. If the repeat passes and the repeat result is not in danger of failing or about to fail, then a problem with the material used for the initial QC run is likely. Some common problems with QC materials include the QC material has evaporated or was improperly stored. The QC material is nearing its expiration and is now unstable. The wrong level of QC was analyzed. You can also have QC that's damaged during shipment, or using a correct target mean for a new lot of QC material. So some things you'd want to do is check the QC vial liquid level, check the QC open vial stability, check the expiration date, check if it's a new shipment of the same lot of QC, and also check to see if you're using a correct target mean for a new lot of QC material. So you want to repeat the analysis using a fresh bottle of QC. If the repeat passes and is not near a limit of acceptance, then the root cause is likely an issue with the QC material itself. If the repeat passes, but only barely so, or is near a limit of acceptance, then the problem is not likely due to an issue with the QC material itself, and further investigation is needed. If the repeat fails, then the root cause has not been determined, and troubleshooting needs to continue. In this case, degradation of this QC material was the root cause of the problem. When a fresh vial of QC material was analyzed, the value was acceptable, and the repeat value was not near an acceptance limit, and there were no further issues. So the short-term corrective action was to use a fresh container of the QC material. So far, we have detected the out-of-control event, stopped reporting patient results, determined the root cause of the problem, and implemented a corrective action. However, this is not the end of the recovery process. We still need to evaluate the impact on previously reported patient results, take steps to mitigate patient harm, and implement preventative actions to prevent recurrence of the problem. So the red bar in the graph shows the QC failure obtained in the previous example. The black bar represents the fact that acceptable QC results were obtained after corrective action was implemented. Now we need to evaluate the impact on patient results. Since the out-of-control event was due to a problem with the QC material itself, it would not have impacted the patient sample results because there was no actual problem with the analytical measuring system. Therefore, previously reported patient samples do not need to be repeated. However, we still do need to implement a preventative action. Since the QC material likely degraded, the laboratory modified the open vial expiration date so that fresh materials will be used more frequently. In the next case, an out-of-control event occurred for level 1 glucose QC. A look back at the Levy-Jennings charts showed that a trend had been developing over the past several QC runs. So the first thing that we did was repeat the QC analysis using a fresh vial of QC. However, that did not correct the problem. Therefore, we know there is likely a problem with the analytical measurement system. The next step we took was replacing the reagent wedge because we know that an unstable onboard reagent is a frequent cause of QC failure for this particular assay. We replaced the reagent wedge and repeated the QC, but the repeat was still not acceptable. We then recalibrated with a freshly prepared calibrator and repeated the QC analysis, but this still did not correct the problem. Finally, technical service was called, and a small leak was found in one of the instrument pump seals. So we determined that the root cause of the out-of-control event was a leaking instrument pump seal. It is important to note that laboratorians should not just keep repeating QC until it passes. After repeating with fresh QC, the repeat failed. Sometimes the technologist will just try another repeat. In this case, however, the repeat would have passed. However, if the QC was repeated more times, the tech would have realized that the whole distribution shifted. So you can see here that numerous QC repeats failed, but a few actually passed. Here there's actually is a real problem with the measuring system. You can see that the whole distribution shifted. However, some of the QC results actually passed just due to imprecision in the assay. So this is the reason why it's a bad idea to just repeat QC until it passes, because you can miss a real problem. You should also continue to investigate if any repeat QC values just barely pass after an out-of-control event, because this distribution shift could have happened. The root cause of our glucose QC failure was a leaking pump seal. Because the analytical measurement system was not performing as expected, and we don't know when the problem started, we need to repeat previously analyzed patient samples. One approach is to repeat all patient samples between the time that the QC failure was detected and the time of the last acceptable QC, when we know the analytical measuring system was performing as expected. However, if your laboratory is a high-volume lab, this could be thousands of samples that would need to be repeated. One strategy to reduce the number of repeats required is to test subsets of patient samples at different time points between the failure and the last acceptable QC result to narrow down the time frame of the event of the error. For example, you could repeat patient samples in groups of 10 at different time points. If results are compared before and after correction of the issue, we can identify the time frame of the event because this is when the repeat values would not match the originally reported values. This slide shows that, in fact, only about 3/4 of the samples need to be repeated. This slide shows a scenario where you may not need to even repeat all patient sample concentrations if only a single level of QC fails. Level 1 QC for glucose was acceptable, but level 2 QC failed high. The root cause was found to be a calibration drift due to the fact that the calibration frequency was inadequate for the stability of the reagent. In this case, since the level 1 QC was not affected and level 2 QC failed high, you would only need to repeat patient samples that have a higher concentration than the target mean for level 1, and you would not need to repeat samples that have a lower concentration from the target mean for level 1 because those results would not have been affected by this error. You need to be very careful using this strategy, though, as it depends on which QC levels were affected, on the magnitude of the error, and also on the direction of the error. So how do we know whether the error is significant enough to require corrected reports? If QC target means and SDs are set appropriately, QC should alert for events that are not yet clinically significant. That is actually the goal of an effective QC program, to catch errors before they adversely impact patient care. However, some events may indeed be clinically significant and corrected reports need to be issued. To help evaluate the impact of an out-of-control event on patient care, the allowable total analytical error should be established. The allowable total analytical error is defined as the overall limit for acceptable imprecision and bias for the result of a single measurement, and it's used to establish the maximum error that can be tolerated without adversely impacting medical decision-making. So this graph shows the distribution obtained when performing measurements on a patient sample with the actual concentration of analyte in the patient sample represented by the mean. The lower and upper limits, as shown by the orange brackets on the graph, indicate the allowable total analytical error. If after correcting the problem, the original erroneous value was within the allowable total analytical error limits, as shown by the green star, corrected reports do not need to be issued because a clinically significant impact of the error is unlikely. If, however, the original erroneous values fall outside the allowable total analytical error limit, as shown by the red star, then a clinically significant impact of the error is likely, and corrected reports need to be issued. So how do we establish allowable total analytical error? The European Federation for Clinical Chemistry and Laboratory Medicine held a conference in Milan in 2014 to establish recommendations for how to determine allowable total analytical error. So this can be based on clinical outcomes, where the allowable error is based on the change of analyte concentration in disease, or the change in analyte concentration expected for a particular therapy. So this type of information can be found in professional practice guidelines and clinical trial studies. Allowable total analytical error limits can also be derived from biological variation studies. So the biological variation is the natural fluctuation of an analyte in a stable patient. Biological variation information can be obtained from databases, like through the EFLM or the Westgard QC site. The allowable total error can also be established based on assay performance. So this would be like bias and imprecision expected for the assay. And you can find this information in the manufacturer's package insert or from the laboratory's own validation data. So this is an example of where to find biological variation data for the purpose of establishing the allowable total analytical error for an assay. You can visit the EFLM Biological Variation Database. So I've shown the URL at the top of the slide. Here I've searched the database for serum glucose. The database provides estimates of biological variation from a meta-analysis of published studies. So when you search the database, you can see the references. You can see them there at the bottom of the slide. And those are the studies used to perform the meta-analysis that derives the biological variation data. The database also has a really handy tool called the Analytical Performance Specifications Calculator that can be selected. And so if you just simply select that calculator, the tool will calculate the allowable total analytical error based on the below equation. For example, the minimum allowable total analytical error for glucose based on biological variation is about 10%. Should be noted that allowable total analytical error may be different for the same analyte for different clinical utilities or for different concentrations of the analyte. For example, the allowable total analytical error for glucose measured by glucose meters in a hospital setting is based on the clinical impact of insulin dosage errors. And so that allowable error is 12.5% for glucose values that are greater than or equal to 100 milligram per deciliter. So the lab director should make the final decision regarding the allowable total analytical error limits selected for a particular analyte. Once we know the allowable total analytical error, for example, 10% for glucose, we now have some criteria to determine if corrected reports should be issued for patient samples after an out-of-control event. Any patient sample where the difference between the repeat result after implementing corrective action and the original result exceeds 10% would be issued a corrected report. In order to perform this evaluation quickly and accurately, we've built a tool to automate the evaluation process. Techs can enter the original patient result and repeat result, and the tool would automatically calculate the percent difference between the original and repeat value and determine which results should have a corrected report issued based on the allowable error. Development of these kinds of tools enables expedited review and more automated decision-making for the technologists. Corrected reports are then issued to accomplish the next step of the recovery process, which is to mitigate patient harm. So here are some approaches to mitigating patient harm after an out-of-control event. So we want to develop data entry templates to quickly identify patients that require corrected reports. We can also call in extra staff to assist with patient sample repeats and also to assist with provider phone calls for corrected reports. We can issue memos to clinical staff in real time, and actually we do provide some templates where the techs could simply plug in the information and issue the memo directly to the clinical staff. We also would need to engage risk management or institutional safety teams if the risk for patient harm is high. The last step in our recovery process is to implement preventive action. The preventive action should seek to prevent the root cause of the problem. For example, the root cause of our glucose problem was a leaking pump seal. Therefore, we implemented more frequent preventive maintenance activities that included pump seal replacements to prevent recurrence of the problem. So one common type of preventive action is a more robust or frequent preventive maintenance program. The next couple of slides show some additional types of approaches for preventative actions. A common preventive action to prevent reporting of erroneous results is to increase the frequency of QC analysis. The regulatory minimum is 2 levels of QC analyzed per 24 hours of patient testing, but many laboratories choose to analyze QC more frequently, like once per shift, or even once every few hours. Increasing the frequency of QC analysis should be considered if the assay is unstable, like the one shown in the graph. This assay is experiencing rapid calibration drift. Therefore, we would want to analyze QC more frequently to catch when this happens sooner and implement preventive action, like shortening the time between assay calibrations. It should be noted here that manufacturers' recommended QC requirements and manufacturers' recommended calibration frequencies are minimum parameters. The lab can always choose to run QC more frequently or calibrate more frequently to help keep the assay stable. QC should be analyzed more frequently if the lab performs large testing volumes in order to limit the number of patient samples affected from a single out-of-control event. QC should also be analyzed more frequently if the results are acted upon immediately with a clinical intervention. In this case, we would want to discover an error quickly so that physicians can be potentially notified before an incorrect intervention occurs. Another way to prevent clinically significant errors is to ensure the QC alert rules are set appropriately to catch errors before they become clinically significant. So one strategy is to base the rules on the sigma metric. The sigma metric relates analytical performance, or bias and imprecision, to the allowable total analytical error, as shown by this equation. So for QC, the bias is typically set to 0 because we want to detect a change from the target mean. You can see from the sigma metric ratio that a high sigma metric, like a value of 5 or 6, indicates a low rate of error because the allowable error is large relative to imprecision, while a low sigma metric, like 3 or lower, indicates a very high error rate because the allowable error is small relative to imprecision. For a high sigma method, a more generous SDI criteria can be used because small biases can be tolerated. You can see that in the first graph, this graph shows a 6 sigma method. For this method, a small shift would not cause the values to exceed the allowable total analytical error. Therefore, a larger SDI acceptance criteria, such as a 1,5S rule, could be used. However, if the method is a low sigma method, like the second graph, which is a 3 sigma method, optimal analytical performance must be strictly maintained. For these types of assays, a more conservative SDI acceptance criteria is needed, and use of QC multi-rules to detect small shifts or drifts or small increases in imprecision should be implemented. This is because the assay performance is poor, and even a small change in the distribution of results can exceed the allowable total analytical error and cause a clinically significant impact. The lab can evaluate the analytical performance relative to allowable total analytical error for all assays, and then focus on developing stringent QC multi-rules if the assay has a low sigma metric. Another great tool that can be used to prevent clinically significant errors is peer group QC programs. These are offered by numerous manufacturers of measuring systems and also by manufacturers of QC products. For most peer group QC programs, users submit daily QC results to the program, and the program will provide a comparison of the lab's QC results to the peer group. So this one is from Sysmex for CBC analytes. The triangles are the lab's QC results. The middle line is the peer group mean, and the white boxes are the limits of acceptability. So in this program, the limits are plus or minus 3 SDIs from the mean of the peer group. Historical data for that lot and previous lots are also provided. An advantage is that this data can be accessed in real time. If the lab experiences an out-of-control event, the tech can access the peer group QC data to determine if the lab's QC value is significantly different than the peer group, suggesting a problem with the lab's measurement system. This peer group program is for oxyhemoglobin results from a blood gas analyzer. We can see that the SDI for our laboratory was high compared to the peer group for 2 levels of QC. So this was an issue that was isolated to our lab. This was resolved by placing a new cartridge of the existing reagent lot on the analyzer. So this was caught before it could impact patient care. So through the use of peer group QC programs, results can be submitted in real time, allowing the lab to compare its results to the peer group. Using the data, the lab can also evaluate QC results for new lots of reagent or calibrator by comparing them to the values obtained for the peer group for that lot. The data can also be used by manufacturers to assist labs with troubleshooting. So in these ways, participation in peer group QC can lead to faster identification of the root cause of an issue and faster recovery from an out-of-control event. Another tool for preventing errors is the use of patient-based real-time QC. In this approach, the laboratory's reported patient sample results are monitored in real time to detect potentially developing performance issues. If the analytical measurement system is performing as expected and the analyte is stable in the patient population tested, then the average of the patient results should stay the same over time, and a trend in the results could indicate a quality issue. In this approach, a variety of ways to evaluate patient results on an ongoing basis can be used, such as moving patient means, medians, exponentially weighted medians, cumulative sums, or other types of algorithms. These patient matrices are calculated after a defined number of patient results are reported, like 40 patient results, for example. The metric results are then compared against acceptability criteria based on allowable total analytical error, SDI limits, or other modeling approaches. Alerts are then generated if the patient results begin to fail acceptability criteria, which can indicate a problem with the measuring system. So this approach is very powerful and can be used to detect small changes in analytical performance that routine QC may miss. However, there are some variables that impact the effectiveness of the tool and need to be optimized. And so these include determining the number of patient results to average, determining a method to identify outliers and extreme values. So this technique really works if the analytes are stable and in the population being tested. So it's not particularly useful for all analytes, particularly those that might not be stable in a particular population, like an ICU population. So you may need to choose analytes that are stable in the population and also choose populations that are stable, for example, maybe outpatient groups to apply this to. Another variable is the magnitude of error that will be used to trigger an alert. So all of these variables need to be optimized through trial and error and simulations. So that can make it technically challenging, but the good news is that there are manufacturer tools available and different software tools available to help you optimize these type of variables. So here's an example of patient-based real-time QC where the mean of every 40 patient results is plotted over time. The graph shows the limits of acceptability, and results that exceed the limits will create an alert. An out-of-range alert means a systematic error larger than the normal variation of the analyte in the patient population has occurred, and this condition could represent an analytical measurement system issue. You can see here that the tool detected a systematic error developing. So this tool can detect analytical problems earlier than routine statistical QC because it's being performed with a defined number of patient sample results, like every 40 patients. However, the technique can produce false alerts. So if an alert is received, the technologist should immediately review lab records to see if they can find a source for a measuring system error, run assay QC immediately just to confirm the alert to make sure it's not a false alert. And they can also run previously analyzed patient samples that were analyzed before the out-of-range alert and then compare those results to those same patient samples ran during the out-of-range alert to make sure that the alert is actually really indicating a measurement system problem. Cumulative summation is another approach that can be used. Calculation of the sums of differences for QC values from the target mean is a powerful way to detect measuring system issues earlier than routine statistical QC approaches. In this approach, the sum of the standard deviation intervals for a specified number of QC results, for example, 33 results, is plotted. If the measuring system is stable, that sum should always be the same. However, if the sum shifts or drifts, as shown in this graph, that means that an analytical measurement system problem may be developing. The advantage to this technique is a more sensitive or earlier detection of errors compared to the most widely used QC multi-rules, especially when the routine assay standard deviation is large or it's a poor performing assay, as shown for alkaline phosphatase in the lower graph. So you can see there that QC, you can see a small drift developing in the alkaline phos QC in the bottom graph, but that drift is greatly magnified in the cumulative summation plot. So this technique can be more sensitive. A disadvantage is that simulations and modeling are needed to optimize alert values, so technical expertise is required. However, automated tools for optimization and implementation are now available from manufacturers. So the next slide shows how the cumulative summation approach works. You'll see SDIs being summed until they hit an alert value. Okay, so you can see that when the cumulative summation of the SDI differences exceeds the alert value, the alert fires to inform the technologist that an analytical measuring system problem may have developed. I think this will show that one more time. And there you can see the alert firing. So this basic approach can also be performed using patient results in real time, so it can be incorporated into patient-based real-time QC approaches. So this table shows a comparison of use of patient-based real-time QC to standard statistical QC. So in terms of frequency, we typically run standard QC maybe 1 to 3 times per day. But for patient-based real-time QC monitoring, we run the program or evaluate the metrics after a defined number of patient samples, like every 40 patient samples. So this can pick up problems much more quickly than routine QC. In terms of phases tested, standard QC interrogates the analytical phase of testing, while the patient-based real-time QC, because we're using the actual patient samples submitted to the lab, will evaluate pre-analytical, the analytical, and post-analytical phases of testing. We talked about how QC is a contrived material and it may not interact with the reagents the same as patient samples. So QC materials may not be commutable, so they may not interact the same way as patient samples with the reagents, and they may not entirely reflect what's happening in the measuring system to patient samples. Whereas in patient-based real-time QC, we are actually using the native patient samples, so by definition, those are commutable. In terms of type of error detected, standard QC approaches are good at detecting systematic and random error, while patient-based real-time QC is really best at detecting systematic error. So for these reasons, patient-based real-time QC shouldn't be used to replace standard statistical QC, but can be used as a complementary approach. So in conclusion, a systematic approach should be implemented by each lab to respond to an out-of-control event. The approach should include two phases, where in phase one, we detect the error, we immediately stop patient testing, we investigate and identify the root cause of the issue, and implement corrective action so we can resume patient testing. Don't forget phase two, which is to evaluate the impact on patient results, mitigate patient harm by issuing corrective reports and calling providers, and implement preventative action to prevent the problem from reoccurring. The allowable total analytical error should be used to evaluate the impact on patient results after an out-of-control event, and can also be used for designing an effective QC program that will prevent errors. Additional tools such as patient-based real-time QC are available that can improve the ability to detect errors and prevent them from reaching clinical significance. So that concludes my presentation, and I'd be happy to take any questions.
Thank you, Dr. Bachmann, for that informative presentation. We will now start the Q&A portion of the webinar. And if you have any questions you'd like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen. So let's get started. Dr. Bachmann, our first question already coming in. When results have not yet been reported, would you suggest to repeat all patient results and change them, or would you also use the approach to just correct results with differences greater than the total allowable error?
So thank you for that. That's a really good question. I would say that if results have not yet been reported, it would be best practice to correct all results from the time the issue was identified to the point in time when the issue occurred, if known, or if not known, back to the time of the last acceptable QC. This ensures that the most accurate results are reported into the medical record. However, if results have already been reported, the decision to issue corrective reports based on allowable total analytical error can lessen disruptions caused by issuing corrective reports for differences in results that have little clinical impact, and would allow the laboratory to focus on timely reporting of those corrected results where the original erroneous values could have adversely impacted patient care.
Thank you so much. Our next question, do you have any recommendations for what to do if your QC is out of control for an extended period? For example, when a QC shifts due to a reagent lot change, but you still need to process patient samples.
Yeah, so regulatory accreditation criteria prohibits reporting patient results if QC is out of the acceptable range. If the root cause of the problem cannot be identified and corrected, the test can be sent out or implemented on an alternate analyzer, or an alternate measurement procedure can be used. In the specific case of new reagent lots, it's not uncommon for QC results to shift when a new lot is implemented. So this is due to what we talked about, which is a matrix effect for the QC material. Because QC materials are contrived, they're manipulated differently than patient samples and may have additives and preservatives or other exogenous materials added to them that patient samples don't have. Their matrix can interact differently with the reagents for the new lot as compared to patient samples. And this can result in a bias for the QC materials for the new lot where no bias is observed for patient samples. So if the QC material bias is big enough to cause QC failure, an adjustment of the QC target mean is required for the new lot. New lots should always be verified by performing patient samples to confirm that there is no bias observed for the patient samples. If that's the case, a preliminary QC mean for the new lot can be quickly established using 10 replicates of the QC material with the new lot to adjust the target mean to get the test back up and running. And then the target mean can be refined once more data for the new lot is available.
Thank you so much, and I also want to thank our audience for these great questions coming in. Our next question, how often should QC be performed? Once a day or several times?
So as we talked about, minimum requirements according to regulatory requirements, at least in the U.S., is to analyze 2 levels of QC per 24 hours of patient testing. Many laboratories choose to analyze QC more frequently, and the frequency depends on several factors. So if the assay is unstable or has poor performance, then you may need to analyze QC more frequently. The frequency would also depend on the volume of testing performed. So if you are a lab that performs a large number of tests per day, you may want to analyze QC more frequently to prevent large numbers of corrected reports having to be issued if there's an error. The lab should also consider performing QC more frequently if the clinical impact of the error for that particular analyte is high, and clinicians act on the values immediately. More frequent QC analysis would detect errors earlier and potentially allow time for corrected reports to be issued before physicians act upon the erroneous results, and also to decrease the number of erroneous values reported before the next QC analysis.
Thank you so much. Now, what should we do with some analytes which don't have biologic variability?
So I assume you're referring to how to calculate the total allowable error for those types of analytes. So there are a number of other resources that can be used if biological variation data is not available. And these are discussed in another CLSI document. It's called CLSI EP21, Evaluation for Total Analytical Error for the Quantitative Medical Laboratory Measurement Procedures. To determine the allowable total analytical error, the lab needs to know the maximum bias and imprecision that can be tolerated for the assay. The lab can obtain this information from clinical outcome studies that determine the magnitude of analyte change that's associated with a particular disease, or that define thresholds used to diagnose disease or change therapy. You would then want to set the allowable total analytical error to ensure that laboratory errors do not contribute to a change in diagnosis or a change in therapy. You can also use knowledge of the known performance characteristics of the assay to set the allowable total analytical error limits. For example, the bias and imprecision data from the manufacturer's package insert or the lab's validation studies can be used.
Thank you so much. And it looks like we have time for just one more question. Dr. Bachmann, I was wondering if you could comment on QC tips for qualitative, yes, no, positive, negative lab assays.
Yeah, actually, that's a really good question. So our laboratory actually treats qualitative values exactly like quantitative QC. So most measuring systems that report qualitative results also report a numerical value that's then interpreted as a qualitative result. So we typically apply our standard combination of QC multi-rules to those numerical results. We would then investigate any shift, drift, or increase in imprecision detected if the multi-rules fail acceptability criteria. For tests without numerical values, so these only report positive or negative, the acceptability criteria, which would be used to determine if the results are acceptable and determine if the number of times when the expected qualitative result is obtained for a QC material was acceptable, would depend on how close the analyte concentration in the QC material is to the threshold of the positive versus negative result for the assay, and also would depend on the assay performance characteristics. So we don't have time to go into the exact calculations, but the CLSI document EP12, User Protocol for Evaluation of Qualitative Test Performance, provides instructions for how to predict the number of results that should yield the expected qualitative results based on method performance characteristics and the concentration of the analyte that's in the QC material relative to the positive and negative threshold for the qualitative assay.
Dr. Bachmann, I want to thank you again for your time today and for your important research. And before we go, I also want to thank our audience for joining us today and for their important questions. Questions we did not have time for today will be answered and posted in the event resources by July 9th. This webcast will be available on demand in the auditorium later today. And if you found this informative and helpful, please share it with your colleagues. Until next time, take care, everyone. Bye-bye.